started. Thank you for everyone who is logged on right now. So this conference today, sort of going with the general theme of this week in America, we're going to talk about alcohol withdrawal, and it's going to be kind of a choose your own conference. So 3 mini cases highlighting a lot of the sort of diagnostic aspect of alcohol withdrawal and sort of early clinical management. Hopefully this conference will finish a little bit early to give everyone a little bit more free time for lunch today. I'm also going to rely on the people who are logged in via Zoom to help participate, whether that's via the chat or just calling out answers out loud. Feel free to do either, but that will make this whole conference go way better. So just a pleasant picture to start out with. This is Maroon Bells. For people who have not been to Maroon Bells yet, I highly recommend going. It is an absolutely beautiful place to visit. So let's get started. All right, so our journey begins with 3 mini cases. So we've got the picture on the left, the one in the middle, and the one on the right. And so if someone in the chat wants to go ahead and give me which picture they want to start with, we will get started. If the chat doesn't participate, then we're going to rely on the room here, the 4 people sitting with me. All right, we're going to rely on the room. Strong start. Okay, people in the room, which picture do you guys want to do? All right, so we're going to start with the sewing. All right, Ava will do Simba next, but we're going to start with the sewing machine. Okay, so chief complaint is a red leg. 45-year-old man with diabetes, hypertension, alcohol use disorder, coming in with 3 days of worsening redness, swelling, and pain of his right leg. He denies any shortness of breath or other associated symptoms. He has type 2 diabetes, hypertension, and alcohol use disorder. He drinks a bottle of rum daily and a few beers. He smokes a pack a day, no other drug use. In the ED, he's febrile, tachycardic, hypertensive, and satting 97% on room air. He has a tender erythematous calf, but no apparent fluctuance. Ultrasound's negative for DVT, and he's admitted for treatment of cellulitis. So I know all of you guys are thinking like, Danny, you just said this was alcohol withdrawal, and you just presented a case on cellulitis. I did that on purpose because most of the people we admit for alcohol withdrawal is sort of a secondary or third problem that we need to keep in mind and not their primary issue. So that being said, which symptom triggered scale will you guys use for the management of possible alcohol withdrawal? So in the chat, I want you guys to throw in your preferred symptom triggered scale, and then we'll also poll the room here as well. All right, go into the room. What's your preferred symptom triggered scale? All right, so we got, perfect. So people are saying defer to the hospital. We got a lot of people saying so's. Graham said he would ask about prior alcohol withdrawals have looked like for him. That's great. All right, so this first case is meant to sort of talk about all 3 of these because one of the more confusing things about our program is we use a different one at every single site, and you have to sort of know the differences between them to help actually treat your patients. So Siwa has these main symptoms. And so it looks at nausea, vomiting, sweating, anxiety, agitation, tremor, headache, disturbances of sort of sensation, and then your orientation or your sensorium. You get less than 10 is called mild withdrawal. Greater than 20 is severe withdrawal. And so based on where you are in that chart, your nurses have a symptom triggered protocol, which will provide the patient some sort of GABA agent, whether that's a benzo, phenobarbital, or something else in the ICU. So that's Siwa. So if anyone can throw in the chat, what is the difference between Siwa and SOS? Perfect. So Ava gets it correct. So there are no vitals in Siwa, and there are vitals in SOS. So this is what SOS looks like. So I listed them sort of in the same order. You get the same sort of physical symptoms. You also have hallucinations. But most importantly, SOS has vital sign abnormalities. So a heart rate greater than 110, a diastolic greater than 90, or a temperature greater than 99.6, which is important because SOS is one of those ones, I think we've all had this experience at Denver Health, where patients who are a bit more savvy are sort of able to game Siwa a little bit, whereas SOS, you do have to have a little bit of objective vital sign abnormalities in order to receive some of the medicine. And then MINDS. So MINDS is sort of goes along with Siwa, but does anyone know when we would use the MINDS protocol? Perfect. So Ariana sitting behind us in the room here says that we use this in the Denver Health ICU, which is perfect. So you're going to see the MINDS protocol in the ED or the Denver Health ICU. And the reason we do that is because this is the only one that's really been validated for ICU patients that cannot respond to questions. So a lot of these protocols require the nurse asking the patient, do you have this symptom? Do you have this symptom? And basing their answer on that. The MINDS protocol allows the nurse to observe the person if they can't speak and score them for one of these symptom triggered protocols. So less than 15 is mild withdrawal and greater than 19 is severe withdrawal. So the reason this is a little confusing is at UCH, we use Siwa. At Denver Health, we use SOS. And in the Denver Health MICU, we do MINDS. And so depending on where you are, you have to sort of know the differences because your patient may receive more or less of a GABA agent based on these. Any questions in the chat about these three protocols? All right. So that was a first really, really brief case. So the big thing to highlight here, SOS associated with vital sign abnormalities, Siwa, no vital sign abnormalities. Siwa has a little bit better validation criteria than SOS, but like we said, it's a bit easier to game the system with Siwa because there is no sort of objective component. All right, so the journey continues. So Ava had already put her nickel down for Simba, which is great. So we're gonna do Simba right now. So chief complaint is cough and shortness of breath. 42-year-old man with alcohol use disorder, PTSD, chronic homelessness, coming in with cough and shortness of breath from a Denver bus station, states he's been coughing for the past day and has increasing dyspnea and reports generalized weakness. He has alcohol use disorder and PTSD. He's got chronic homelessness, no tobacco use, no other drug use. His vitals, he's afebrile, tachycardic, hypertensive, and satting 86% on room air. He's no acute distress. He has crackles in his right lower lung field. He has a right lower lobe pneumonia, and he's getting admitted for treatment of his community-acquired pneumonia. So again, a patient whose alcohol use disorder is not their primary problem. And the question here then is, what other information do you want to know about this patient's alcohol use history? So I want everyone to throw in the chat as many questions as you would want to ask this guy if you saw him in person, so we can figure this out. All right, so great. So Anita, Jack, and Kara are all crushing it right now. So last drink, seizure history, has he been intubated? Has he ever been in the ICU? How much does he drink? When was his last drink? Graham says, is he a professional withdrawer versus an amateur withdrawer, which I think is getting at some of those sort of intubation seizure questions. Ava asked about other ingestions, which is perfect. Awesome. And so if anyone wants to throw in the chat, why did you guys, where did those questions come from? Did those come from your personal clinical experience, or are those based on something else? All right. Yeah, so Ariana says, those are all questions I've asked before, which is great. And you've sort of seen everyone ask those before. Yeah, great. And then Miranda says she doesn't know if there's a formal score, but that's how she gauges the risk of her patients who are coming in with possible alcohol use and concern for withdrawal, which is great. So spoiler alert, there is a score, and you guys basically all created it with your questions. So to answer your questions, this guy's last drink was 24 hours prior to admission. His drinking habits, he drinks 1 to 2 pints, which is about 470 milliliters per pint. So that's about 470 to 900 mLs of vodka per day. He has had prior admissions for alcohol withdrawal, but he's never seized, he's never been intubated, and he's never had DTs as far as he knows. And so here's a score, and you guys basically all just described this perfectly, but it's called the Prediction of Alcohol Withdrawal Severity Scale, or the PAWS, which is where the Simba paw came from. And this is from a group, Maldonado et al., in a journal aptly named Alcohol from 2014. And what they did was they basically set up a scoring system after reviewing thousands of charts at a New York City hospital, and then retrospectively looked at it and then prospectively validated it in patients who were coming in with concern for alcohol withdrawal. And the whole point of this scale was to give us another tool that we can use to predict the people that will get worse once they're in the hospital and need that symptom triggered therapy. So Based on what you guys just put in the chat, you actually hit a bunch of the pause, but it helps us risk stratify people for complicated alcohol withdrawal syndrome, which is formally defined as hallucinations, seizures, and or delirium tremens. Delirium tremens, also the name of a beer, which is like, I think 10 or 12% ABV and pretty good. But delirium tremens more formally refers to hallucinations and seizures with autonomic dysfunction. Okay, so here's the pause, and I'm gonna let you guys just take a quick look at that as I sort of talk through it. But basically the first question, the threshold criteria, asks you to ask the patient, have you had alcohol in the last 30 days? I think pretty common sense, if you haven't had alcohol, it's really hard to withdraw from alcohol. And so you have to have been drinking. And then you get into questions that you guys all already ask people, regardless of what the admission is. So have you been intoxicated or drunk in the last 30 days? Pretty easy to tell based on your history. Have you ever had alcohol withdrawal before? Have you ever experienced withdrawal seizures? Have you ever had DTs? Have you ever undergone alcohol rehabilitation treatment, which is something that we usually get to by day one or day two, but probably something good to ask up front. Have you ever blacked out? Have you ever combined alcohol with other downers, which is what Ava brought up in her question during the last 90 days? And have you combined alcohol with any other substance of abuse during the last 90 days? And then you combine that all with their BAL on presentation and any evidence of increased autonomic activity. So a heart rate above 120, tremor, sweating, agitation, and nausea. So essentially the things that Siwa and SOS are looking at, we put those into the clinical evidence portion of this score. So what do you guys think, based on sort of these yes and no answers? Every yes gets you 1 point, so it's sort of all weighted the same. What do you guys think an abnormal score is gonna be? All right, so Alex in the room says he thinks 2 to 3. We'll do a Jeopardy style, or I guess Wheel of Fortune style. People want to go over that or under that? Cool. So Ariana says 5 to 6. Hannah says she wants to go higher than that. Corey, oh, it's price of right. Excuse me, Corey. Excuse me for my malfeasance. And Kara says greater than 3. So the correct answer is greater than 4 is a high risk for complicated alcohol withdrawal syndrome. And that is not a typo. That likelihood ratio, which has been validated from about thousands of patients, is 174. So Corey loves likelihood ratios, perhaps more than he loves his own children. And as Corey will attest, that is too many likelihood ratios. So a likelihood ratio of about 10 increases your risk of something about, I think 40 to 50%. So I don't even know what a likelihood ratio of 174 is, but it's high. So things you guys are already asking, if you have a chance, you can throw it into the pause calculator on MD Calc, which is what these pictures are from. And you can basically sort of have an objective piece of evidence to tell your attending or tell the nurses when you're admitting a person who may withdraw. Any questions about the pause score? Excellent. So I'll say, yeah, so Hannah asked what the total score is. And so the total score that you can get here is a 10. So if you get a 10, the interesting thing about the score is there's no additional validation between a 4 and a 10. And so essentially if you're above 4, your likelihood ratio is 174. If you're a 10, your likelihood ratio is 174. And this is actually a plug. One of our now nocturnists, Josh Rains, loves this JAMA series called sort of the Rational Clinical Exam. And they do a really good piece about, will my patient develop severe alcohol withdrawal? And they advocate for using this score in essentially all of our patients. So I recommend both the JAMA series, Dr. Rains' style of doctoring overnight, and using the pause score. Ariana disagrees. All right, any other questions about the pause score? Perfect. All right, so we are flying through this, which is great, because I think arguably this last box here is the thing that I use this whole conference as an excuse to talk about this last box. So does anyone in the chat want to take a guess as to who Maurice, Red, Bob, Tom, Charlie, Jack, Al, Junior, Slim, and Tony are? All right, so Ariana goes with musical group. Not correct, but I like the guess. Anyone else in the room have any guesses as to who these 10 people are? Corey says they're Sopranos, which maybe, great guess. All right, so these 10 gentlemen all make an appearance in this 1955 study. So I cannot recommend this study enough. There's a lot of really questionable things in it because it's from 1955. But if anyone is interested in this study when we're done talking, shoot me an email and I will send you guys the PDF of it. So the name of the study is an experimental study of the etiology of rum fits and delirium tremens. And this study is actually the study that sort of told us what the autonomic symptoms and the physical manifestations were of alcohol withdrawal. So this study is from 1955 and is considered one of the landmark studies in toxicology. So this is the block quote from the beginning of the study. And I'm just going to read this almost in full because I think it's fascinating and shows why, now IRBs and consent are important. But it did not seem possible to obtain a definitive answer on the basis of clinical evidence alone, and since no one has succeeded in inducing DTs in animals, an experiment was conducted in which volunteer subjects, all former morphine addicts, consumed large amounts of alcohol for periods of up to 87 days, following which the alcohol was abruptly withdrawn. So, this study was designed to answer the question of what happens when you induce alcohol use disorder in a human being, and then you withdraw that alcohol abruptly. So this is going to be a rapid fire journal club. So what were their methods? So they took subjects and housed them in a closed ward under 24-hour observation. And so what that meant was these 10 subjects were all essentially in a floor of what they called then like an insane asylum, but now we would call sort of an addiction unit. And they had a one-to-one sitter who followed them around with a notebook and basically observed every single thing they did and made notes on every single thing these people did for 24 hours for the duration of the study. So who were these subjects? Another block quote, all the subjects were former morphine addicts who were serving sentences for violation of the Harrison Narcotic Act and who volunteered for the experiment. That word volunteered is doing a lot of work in that sentence. And I think a lot of people have doubts about how true that really was. So former morphine addicts, I did not know what the Harrison Narcotic Act was until this morning, but the Harrison Narcotic Act is sort of seen as one of the beginnings of the war on drugs in America. It came out in 1914 and it basically taxed opium and cocaine coming into the US. One of the sort of unintended side effects of the Harrison Narcotic Act was it also put a penalty which could carry a fine or even imprisonment on doctors who prescribed opiates or cocaine to people that had addiction, because addiction was not seen as a medical problem. So this was the sort of the first act that criminalized owning opium and cocaine for non-medicinal reasons, and also criminalized the act of prescribing it unless you had appropriate ability to do so. That drug has essentially gone away, but one of the kind of long-lasting effects is there's warning labels on everything now saying that substance may be addictive, and that was one of the byproducts of the Harrison Narcotic Act. So we no longer study prisoners for just this reason, because how can you volunteer for something if you're currently in prison? There are quite a few conflicts of interest. So all subjects have been abstinent from morphine for greater than 3 months before beginning the study. And if anyone's interested in reading the study, it's written like a book and it's about 33 pages, and they actually describe every single subject's basically personal life, problems they were having, their psychological profile. A lot of stuff is now fallen out of favor, and they say some things that are really horrible, but it's really interesting how it's written. Okay, so what is the experiment? And this is when it starts to get really insane. So they divided people into 3 periods. So there's the preliminary control period, which lasted about a month, the chronic intoxication period, which we'll talk about, and the abstinence period. So the chronic intoxication period, and again, I'm just going to read this in quotes because I think this is insane, but it was planned to administer alcohol in amounts sufficient to maintain the maximum degree of intoxication compatible with safe ambulatory management, which is grade 2 on a scale of 1 to 4. 1 being you're not tipsy at all. 2 is you're a little tipsy, maybe you're stumbling around. 3, you're slurring your speech and you can't really function. 4, you're in a coma. Continuously for 6 to 12 weeks. They allowed the participants, in quotes, to dilute the alcohol with 3 volumes of water or fruit juice, and they were allowed to take a chaser if they needed it to get the alcohol down. So when I first read this study this morning, I thought to myself, oh my God, they did what to these people? So this, again, I'm just going to read this in full. So they have these people's names throughout the study, which sort of gives it a very personal feel, which is weird. But they began with 10 milliliters of 95% ethyl alcohol every 2 hours from 6 a.m. to midnight. So for those people that are not familiar with sort of percent alcohol ABV versus proof, 95% would equal 190 proof, which is the same proof that you'd find in something like Everclear or grain alcohol. So one way to think about this is these people were basically doing a shot or a shot glass worth of grain alcohol every 2 hours, every single hour or every 2 hours they were awake for the entire duration of the study. So they titrated the alcohol for 4 to 5 days until people got sufficiently intoxicated. And then they sort of kept them at a steady state, as drunk as they could reasonably keep them while functioning for as long as possible. If their nausea and vomiting occurred, they gave alcohol in small amounts and at more frequent intervals to sort of tamper down that symptom. So Anita is saying this study is making me nauseous, which is an absolutely appropriate response to seeing this.
Just like Cole's comment, 1 man, 10 parallel, I think, sure.
Yeah, yeah. So what were the results of the study? So I'm going to pause here for a second. I want people to throw into the chat what you guys think the study ultimately showed us. And keep in mind, this is in 1955, where we weren't actually sure what the alcohol withdrawal syndrome looked like. And then people in the room, feel free to shout out some stuff.
There's some drama that happened in this.
So Alex said some drama happened. Maybe some people escaped. Ava appropriately said we need to regulate our research ethics better, which 100% agree. This is not the reason we don't study prisoners, but it probably was taken into account. All right, so what happened? So this is another screenshot from the actual article, one of their tables. And so just to kind of walk you guys through it, so they list all 10 patients down the left column. They show each of their weights. They show the number of days that they continuously drank for and the amount of ethanol or ethyl alcohol or grain alcohol that they consumed during the daily period, how many days they maximally drank for, what that amount looked like, and then sort of their average drunkenness scale, with 1 being a little tipsy and 2 being like pretty drunk, but not, stumbling or unable to speak. And so what you'll realize, if you look at sort of the average amount of alcohol for the entire daily period, these people were basically drinking about a pint of liquor a day for the entire duration. So notably, the first 3 people, Maurice, Red, and Bob, only lasted 7 days, 16 days, and 16 days respectively. And they essentially opted out after 16 days because they could not handle the continuous daily intake of alcohol. But Tom, Charlie, Jack, Al, Junior, Slim, and Tony really went for it and drank for a while. So Tom looks like he was sort of the mildest here, and he still drank for 34 days. So these people drank for an average of about 50 to 80 days continuously. And of those days, they were drunk or had reached the desired level of drunkenness for about anywhere from 30 to 70 straight days, which when I saw this, I got very nauseous just even thinking about that. So this is just the total amount of alcohol consumed and how long they lasted in the study for. And keep in mind, throughout this entire time, they have a person sitting or standing next to them, writing every single thing into a notebook. So this is the table that sort of changed the way we think about alcohol withdrawal syndromes. And this is the table that sort of became one of the landmarks of early toxicology. So if you'll look here, these are the patients, the research subjects who drank a lot. And across the top, we have abbreviations for every alcohol withdrawal symptom. And if you look down here, you'll notice that all of these symptoms listed down here are now included to some degree in Siwa, SOS, or MINDS. And they scored every single one of these on a 1 to 4 scale. So 1 being you had the very mildest symptom, 0, it wasn't there, 4 being it was so severe that it was life-threatening. And if you'll notice, almost everyone or every single person had some degree of tremor. Every single person had some degree of weakness. And then you can sort of go through the rest with sweating, blood pressure, nausea, vomiting. All of these things were there. And notably, they were all more prominent and more severe in people that sort of persisted in the study and kept drinking. So if you look at the top for Maurice, Red, and Bob, you see a lot of 1s and 0s. So they look very, very binary 3 lines. These people had very, very minimal symptoms, and their symptoms lasted fewer days. So again, I'll defer to you guys in the chat. What would your takeaway be just looking at this table? If you were a 1955 researcher, what would you think looking at these results? And people in the room can call it stuff too.
It's like 2 of them went into DTs.
Yeah, so Alex says that a couple of them, only 2 of them developed DTs, which is great. So DTs is it's like the convulsions tab. It's sort of a combination of these down here, but very few people developed DTs. Yeah, Miranda hit the nail on the head. So if you drink more, you get symptoms for longer, and more drinking appears to be associated with more physical and autonomic symptoms. And
It's interesting for Charlie that they have a question mark in duration of days, meaning like they couldn't really quantify like.
yeah, great. So Ariana brings up, what are these question marks in Charlie? And this is where I would advocate like actually reading this paper if you guys get a chance, because it's fascinating. So Charlie almost died. And when Charlie almost died, they actually had to treat him with basically the early equivalent of phenobarbital, ice packs, and a ton of other stuff to make sure that he didn't die in the unit. And then they were not able to tell at that point on whether any of his delirium or confusion was due to the immense amounts of phenobarbital he was getting or the fact that he was withdrawing. And they describe all of this in extremely vivid detail in the entire paper. So this is kind of the good news, though. This is like a happy ending, and something that I think we can all talk to our patients about going forward is there's this block quote in the last paragraph of the article. 3 months after alcohol had been discontinued, the subjects were again given physical, psychiatric, laboratory, and psychological examinations, and no significant changes from control status were detected in any of these measures. So after the study was done, none of these people drank again because remember, they were all still prisoners. And so 3 months after this was done, all of them were back to their pre-study baseline. So they had no long-lasting physical, psychiatric, or sort of psychological effects from this, which means that the takeaway here, most importantly, is if we can convince our patients and get them plugged in with the right resources, abstinence from alcohol, you can essentially recover back to baseline, assuming you don't have any other sort of horrible chronic complications from it.
The very long description, but did they talk about cravings at all?
Sorry, say it louder.
Did they talk about cravings at all?
Yeah, that's interesting. Like, did any of these people, if they were like predisposed to alcoholism, if any of them like, yeah.
Yeah, so Miranda and Ariana brought up the question of cravings, and it's not really mentioned at the end of the article. So one of the fascinating things is they talk about cravings at the beginning, and so as they were building these people up to that steady state of drunkenness, I think about half of them wanted to drink more because they thought that they weren't consuming enough, and so people had cravings at the beginning, but they don't talk about cravings at the end. And then Ariana also brought about, were there any people that were predisposed to alcohol use disorder or anything like that? And there were. So in the sort of official descriptions of these people's past lives, I think over half of them had prior alcohol use problems and had been abstinent for a little bit of time, but some were drinking like basically up until the sort of control period before the study started. And so this in a lot of respects, these are sort of real world people that we would see. They didn't have any resources back in 1955 to help these people outside the hospital. So a lot of them were sort of recurrently incarcerated for a number of reasons. But it's a very real world cohort. So what were their takeaways? They have 10 takeaways at the end, which honestly is probably a better way than we write our studies now. They bulleted it and it was fantastic. But 6 of the patients drank for 48 to 87 days, which again is a lot. And then following abrupt withdrawal of alcohol, all patients developed tremors, marked weakness, nausea, vomiting, diarrhea, hyperreflexia, fever, and hypertension. So this was the first study that basically provided hard, concrete evidence that this is what the alcohol withdrawal syndrome looks like, and sort of set the stage for the next couple decades of alcohol withdrawal research. 2 patients had seizures, 3 had frank delirium, 2 had visual auditory hallucinations. And basically what they pointed out was that this occurred despite the fact they gave people a healthy diet, they gave vitamin supplements, and they monitored them closely. And then as Miranda pointed out, these symptoms correlated roughly with the amount of alcohol consumed and the length of the period of intoxication. So the longer you drank and the more you drank, the worse your withdrawal symptoms were, which I think all of us can attest to after, residency or at least even a couple months of intern year, that we see this routinely. Notably, they also point out in the study, which I didn't have room to include here, that you do not need to have a blood alcohol content of 0 in order to withdraw. So people that had a routinely higher blood alcohol content started to withdraw while they still had alcohol in their system. This study did some really interesting things where they actually measured people's blood sort of breath. You basically used like a breathalyzer to correlate it. And so they did some really interesting stuff with alcohol metabolism, which is also listed in the study as well. So takeaway here, these are the physical symptoms. Anyone can withdraw who's been drinking for a long period of time, and we should be on the lookout for that. So what were the learning points from this relatively short noon conference? So we discussed this sort of the history of the rum fits article, which is the 1955 landmark article by Isbell et al. We talked about the pause study, which we can now use to help categorize our patients that may be high risk for alcohol withdrawal, severe alcohol withdrawal syndrome. Talked about what severe alcohol withdrawal syndrome looks like and sort of why we now think that that collection of symptoms exists based on the rum fits article. Talked about why Siwa and SOS are different. SOS has a vital sign component, which makes it a little bit more objective. And then we talked about, we didn't actually talk today about medications utilized for the treatment of alcohol withdrawal. We just sort of broadly stated that those were GABA agents. And that's it. That's all I got. So any questions from the chat about alcohol withdrawal?
Danny, can I make a quick plug?
Yeah, go ahead.
So one thing that like Julie Taub over at Denver Health emphasizes is this front loading of these certain selected patients. So the ones who like wind up in the ICU on Prestex strips. And what she says is that, if you allow these patients to really get into serious withdrawal, it sort of primes them for the next withdrawal. And that there's sort of this like continuous priming process. The more they withdraw, the like more likely they are to seize and wind up with serious complications. So she really advocates for these people who are like real professionals to get like, loading doses down in the ER and really like try to get ahead of it, or else you sort of get behind it and you're taking away like nursing resources and really like doing sort of bad things and chasing stuff.
Yeah, I think it's a great point that Graham brings up. And that's one of the reasons that a lot of our ICUs EDs use the MINDS protocol, because the MINDS protocol gives a little bit more medication than Siwa or SOS right off the bat. And that's also the reason you'll see at Denver Health why some people are getting loaded with diazepam or Valium in addition to the phenobarbital they're getting. Anyone else have any other thoughts or questions about the conference?
I think the pause score will be helpful to kind of risk stratify people, because I think I've never heard of that, but I mean it happens all the time where like you're in the ICU and you're like, yeah, sure, we'll take them, or you're kind of unclear whether they're flu or ICU appropriate, but that could be something to help stratify maybe where they go. Yeah,
Ariana, for those that couldn't hear, brought up that she thinks the pause score, she's going to probably start utilizing it if she's on an admitting shift and helping her sort of triage ICU versus step down versus floor. And so if that pause score is high, maybe that pushes you to put them in a step down or ICU place where they could reasonably receive more IV medications, have more nursing support, et cetera. And then Anita asks, she's curious why UCH uses Ativan for SOS versus phenobarb, diazepam, which are better agents for alcohol withdrawal. Great question, Anita. Does anyone in the chat know the answer to this one or have any thoughts on this? Because I know we've got a lot of residents who have sort of been very active in working on the UCH protocol.
Isn't it that one of the major studies was at Denver Health, and they used phenobarb and diazepam over there?
Yeah, so Ariana brings up a great point. So Denver Health is sort of a national leader in the ED at least, and the like Julie Taub and her addiction team at using phenobarb and diazepam for treatment of these people. And so a lot of the data for this comes out of Denver Health and in association with a couple other centers. So that's one reason Denver Health uses it. And I think to Graham's point, phenobarbital has a bit of a longer half-life than Ativan. And so phenobarbital is a better medication generally for sort of front loading and controlling symptoms early than Ativan. But I do not know the exact reason as to why UCH chooses Ativan versus phenobarb.
I don't know if it's specifically for UCH, but Ativan, I think, has less liver risk, and so if you're in the ED starting this off and you don't have much info on the patient, it might be the lower risk first move.
Yeah, and Graham brings up a good point, which Miranda was just saying in the room too, is that Ativan is safer in the elderly and liver impairment. So even though phenobarb may look better in studies, you still need to use Ativan for a number of patients because it's phenobarb will just never be cleared. Anita says, hopefully the protocol switches soon. My experience at UCH is a lot of people are not comfortable with phenobarb, unlike DH. I would agree with that 100%. I think generally, we see more of this at Denver Health, and I think all of us are more comfortable treating this at Denver Health, and so I agree. For anyone that's interested, Jess Coulter, one of our second-year residents, was doing a ton of work this past year before COVID, looking into the protocol here, along with some of our now graduated third-year residents. Because I do think there is sort of some room for improvement in our own practice, but across all of our sites. Any other questions? All right, thanks guys. I hope everyone learned something today. Hopefully the rest of the day is as stress-free as possible on November 3rd, 2020. If anyone has thoughts, questions, or concerns, don't hesitate to stop by your respective chief office. We are here to talk about just about anything for the today and the immediate future. So everyone have a great day.